Evening, everybody. As Piret told, we have been hearing about the total care of patients and family, and many a times we talk about physical and psychosocial aspects, and we also understand that the spiritual care is not very much done, or it is done partially. In India, in palliative care. Uh, so we thought of bringing some light on this spiritual care, and we have an eminent faculty, Dr. Piret Paal, with us, who did her PhD in 2011 on the experiences of cancer patients at the University of Helsinki, Finland. And she has worked in Europe and conducted research in palliative care units, long-term care facilities, and hospices. She's a teacher, a researcher, and was deputy director of WHO Collaborating Center in Nursing Research and Education at the Institute of Nursing Science and Practice at the Paracelsus Medical University in Salzburg, Austria. And she was appointed as a lecturer in nursing palliative care in 2021. And her work and research is mainly dedicated to improving access to palliative and end-of-life care worldwide. But her special area of interest is spiritual care. And she led the process that in 2021 resulted in the publication of the European Association of Palliative Care white paper on multidisciplinary education for spiritual care and palliative care. And presently, she is the director, Institute of Palliative Care, Paracelsus Medical University in Salzburg, Austria. And I welcome Dr. Piret Paal to this session, and it's over to you, Dr. Piret Paal.
Thank you so much, and good evening to everyone. It is really lovely to meet you, and I congratulate you for reaching the 29th session of this training program. So and that also that you are so motivated that during the Saturday evening you come and study palliative care. So I think that we are kindred spirits already. I have to tell you that my talk today will be all from European point of view. And I am so aware of that tonight I had actually a nightmare that I was 15 minutes late for this session. And then I told about some kind of health problem, and immediately someone from India said that gave me a diagnosis that was directly connected with some kind of spirits here. So that was my dream. And then I was like, I don't know anything about religious practices really in India. The only thing that I know is that you have much more gods than we have in Europe, so we just have one, and so and even we are very bad with this one god here, so we cannot get it really integrated in our medical practice. So let's see how this session goes. And as we have quite little time, and I'm very passionate about this topic, I want you to introduce me via one very little exercise that I prepare specially for you. Now, so don't think that you can keep this session going and you don't have to do anything. It's interactive course, so be prepared, you know. I will copy to the chat a link. Press on that, and then you will be in your browser. It opens a page. It's a Padlet page where you can write down your own understanding what you think spirituality is for you. What does it mean for you? There is on this page, there is this kind of plus on the bottom of the page. Click on that, and then you can start writing. And I think that your contributions will be anonymous, but we will see about that. So you don't have to be afraid that others will see what you write. I hope that I managed to get it done like this, but even if it's not, it's a trusted realm, space, so please be so kind and write down your understanding what spirituality means to you or what it is for you. So you should end up on this page here. And at the bottom of this page, there is a plus. And then if you click that, then you can start writing. Oh, let me see, maybe I shared the wrong, let me see once more. Yes, well, that should be the link. Does it work? If it doesn't work, please let me know. Maybe that is the correct, it's the same link. I should see you all there that typing. Oh, I see where you come from, but I don't see what you are typing. Okay. Huh? I think if you go to your name, you have an opportunity to write something there. But I see someone has written meaning of life. Yes. Well, obviously, I have done something wrong with that exercise. Or there we go. It's always this online so, but I saw already, like somebody wrote that it is meaning of life, or it is somebody might say it's nature or it's religion, and so I am not sure why now this Padlet is just showing me your place where you are from, but well, usually I have got this kind of nice descriptions. Obviously something didn't work as I already expected in my dreams this night. So yeah, I see you are not able to, don't worry. So I just wanted to give you an opportunity. At least I saw you come all over India, for example, which is very excellent. But anyway, so I will now, instead of I will then start with my presentation. I hope you can hear me okay, maybe not. If you can hear me well, can you hear me okay? Yeah, okay, good, thank you. And then I start with my presentation, and then we will make some breaks in between, but I just want to get you on one page, what are the struggles? So, because if now this exercise would have been working, then you would have seen that people, even if you think they are similar to you, they have quite different understandings what spirituality is. And it goes back that long that even palliative care and spiritual care can be compared to each other. And I will add to this nursing care as well. Spiritual care and palliative care both have this kind of background, that it's not only care that where we focus on bodily failures, but we provide more care than just this kind of bodily care. We provide more than just medicine. It has even been told that it's when this kind of material component is missing, when we don't have drugs, when we don't have herbs, when we don't have anything really, then we always have this kind of human capacity. And we have this kind of human presence that also can help people to cope with their situation. So and so therefore there is I just put you like two definitions here. One is about spiritual dimension, which was written down by WHO in 1991. And the expectation in this Health for All strategy was that by 2000, everybody should be able to provide spiritual care as well. Our aspirations in palliative care have been similar for the past 40 years at least, or in palliative medicine, where next to curative treatments, treatment of pain and other symptoms, also psychological, social, and spiritual problems should be treated to provide the best quality of life for patients and their close ones. So, you can yourself think that how far have we come? I don't know, 40 years seems like a long time. On the other hand, it is also a very short time. And I think that everybody agrees with me that there is still improvement both in spiritual care and palliative care. In Europe, and as well as in the United States, nurses have been very, very active also in the area of spiritual care. And also many of them argue that the whole person care basically is spiritual care also. And so it is the basic nursing care. And I have from one history book here, a citation from the school where Florence Nightingale herself studied, that the nurses were trained like this, that when the physician can help no longer, the love of the nurse is still working. If you stand by the dying person with a caring hand and a gentle mind, so you bring him or her relief and consolation. So it's about this kind of being there as a component, essential component of nursing care. And nowadays, we have come to this situation where nurses are also so well trained that they say that I have so many things to do, and they're very proud that they do this kind of physical care and provide very good physical care. But this leaves sometimes patients and carers with a void where they seek for something more but do not find it. And that's why also there is a definition from 2010 that the spirituality is kind of thin and vague notion, but we understand if it's missing. So it's much more easily described if it's missing in the care situation. So, and I think that physicians themselves have been most reluctant to deal with that, and that's why and there is of course like a profession which is like broad certified chaplains who are very responsible for who are like kind of professionals of spiritual care. But we have from 2011 a working definition from European Association for Palliative Care. And we named it especially a working definition, saying that it's not ready. So we need more evidence, we need some more research around this topic. And the funding for research is very difficult to find to study solely spirituality. And so it's always the last thing that comes is the spirituality. And it looks like this working definition is working in a way that even there is a nurses curriculum in spiritual care in Europe now, and they also adapted this definition for spirituality and spiritual care, which actually comes from palliative care. And so it says that it is a dynamic dimension of human life that relates to the ways persons, individual and community experience, express and or seek meaning, purpose, and transcendence. And this is the transcendence that can be here as well. It doesn't have to be like in some kind of other spheres. And also the way how people connect to the moment, to self, to others, nature, to the significant or the sacred. And I think that you hear sometimes people don't want to talk about spirituality. They think that existential care is a better term. So what are these existential challenges? What we have if we are confronted with the serious situations in life, for example. So you ask for the meaning, you ask for the why you're suffering, you ask why I have to die now. There is guilt and shame. There is reconciliation and forgiveness, but also things that we, and hope and despair, obviously, but also love and joy. So there is much talk about spiritual needs in patients, but rarely we ask what brings them love and what brings them joy. So spirituality is also an uplifting phenomenon in our lives or dimension. And so we should also focus more on this fulfillment and love and joy, but there is really nothing to report scientifically on this. It is maybe only studied in midwifery in connection with when children are born or something like that, but nothing really from palliative care. And then, yes, so what are the values of this person? What matters? Family, friends, work, things, nature, culture, ethics and morals, but life itself as well. And obviously religious considerations and foundations like faith, beliefs and practices. So also rituals have a very important, it's actually already inside the word spiritual. So also rituals can have an important role in taking care of patients in palliative care. Then, of course, there is a quite interesting editorial published in Palliative Medicine. So and I think it's an honest question. I mean, like, does it matter if we don't have a definition of spirituality? And so if we have the CAPC definition, what we just showed, everybody can use it as they like. Every patient can define what spirituality is as they like, but it is so broad that ultimately it can be also meaningless. It doesn't mean anything. And of course, then if we think medically, we leave ourselves also in this kind of weak spot in terms of doing research because we cannot use the methods that are usually used in evidence-based medicine. And that's why we don't have also sufficient evidence to argue that why spirituality is so important. But I think those of you do research in palliative medicine, you also know this problem that if we have two cohorts and we have a cohort that receives palliative care and then we have a control cohort, then it ends up that also the control cohort is so happy that somebody just talked to them that you don't see any statistically significant differences between those groups. So yeah, and so the same struggle also applies to spirituality and spiritual care. And then those guys, Martin and George from UK, come to a conclusion that this debate is that should it be called existential care or spiritual care or religious care, whatever its name, there seems to be this peculiar aspect of living called spirituality. So they come to a conclusion that this is still important. And about that time, I also launched, as a member of the EAPC Spiritual Care Reference Group, this kind of idea that we need a white paper, that what healthcare professionals need to know about spirituality and spiritual care. And we already had this kind of EAPC 10 core competencies that everybody who works in palliative care should have. And one of those is spiritual care competence. And it consists of 4 domains. And we will look at these 4 domains more closely. And I will explain you about those 4 domains a little bit. So what we in our white paper thought that it is important to know. And so this paper was published 2020, and it has been quite popular. Because people just like, we summarized lots of information into this white paper. And so we come to this first competence, which says that each person working in palliative care should be able to demonstrate the reflective capacity to consider the importance of spiritual and existential dimensions in their own lives. So instead of focusing on patients, this calls out every one of us to focus on ourselves. And the idea behind this is that if we don't know what is good for us, how can we give advice to those who we are supposed to support? Obviously, there is a need to know what meaning of spirituality is in healthcare setting. Why do we need it? And then also knowledge of essential themes and questions. So such questions as the why questions, why me, why now, and how to appropriately react to those. But self-reflection is seen as a very strong component, this kind of how much can I do? How much can I provide? People in palliative care are constantly overwhelmed. We can help people, but they still die. That means how much death can we take? How do we cope with that? You always probably notice that when your family life is out of sync, you are out of sync as well. So what is your basis? What gives you this kind of inner strength to continue doing your work? And we know that the burnout rates are very high in palliative care as well. Is your team supporting you? Is your team seeing what you need actually? So this kind of organizational situation around you is also supporting your spirituality. And if you are out of sync, what can you do to get back to be the best person, or to really recognize who you are as an individual? And if you don't have this, I know everybody gets now so angry. Everybody says like, yeah, well, I have to do this because if I'm not doing, nobody is doing. But really, even Eduardo Pruera from United States says that it's not your personal task to fight your burnout. It's the task of organizations and teams to support each other. And so if you are out of sync, don't go and try to spiritually guide somebody else if you are not there yourself. So this said, I know, yeah, think about that. Then the second competence is to integrate the patient's and family's spiritual, existential, and religious need in the care plan. So obviously we cannot do very much. So the goal and limit should be made clear, like with any other treatment, why we do it and what can we achieve with that. Also consciousness of time and place. When I ask my medical students, so what is the best place to have a spiritual conversation? They always look out the hospital and say, in the garden. But obviously we cannot go into the garden each time we want to have a spiritual conversation. So look around you, look for a spot where you have maybe a little bit of peace, where you are able to listen. Then also recommend a care plan based on patient's reaction. So if you get a reaction out of patient, integrate into the care plan, which means documenting, which means making suggestions, making referrals maybe to other professionals who can help and support you and the patient. And then, as I said, with palliative care trials, also with spiritual care, it's a communication very often, very personal communication, and it always triggers some kind of intervention effect. And that's why always follow-up is needed. And we seem to forget about that. If we trigger something in people, those who are in a vulnerable position, we hurt them even more if we do something that we are not clear about what's the purpose of doing so. And to the second competence, I think it's a very essential also statement that you have to respect the patient choice not to focus on this aspect of care if they wish so. So it can be that 50% of patients, like also with advanced care planning, 50% of patients say, I don't want to do advanced care planning because I don't want to think about death and dying. The same applies to spiritual needs as well. They say, well, it's not your business. So leave them be. But when patient says no, it is still very intriguing to think and understand why this no and where this no comes from. Is it some kind of previous experience, bad experience? And obviously people are not trained about, like not anybody in palliative care, nobody in nursing really, but also general population. They might have a very different understanding of what are you actually asking or offering them, yes? And patients may say no and laugh, and then you think everything is okay. I always tell to my nursing students and medical students, if someone has a very good humor, we feel that it's very good to take care of them, and they are easily approachable. But this humor can be also the defense mechanism, and so it's an art of healing to go beyond the words and understand, for example, that why this person has put up this kind of barrier and why they don't want to talk with you. And so this no, if you go a little bit further, may become a yes, actually. And so it's important to offer and then maybe withdraw and go again, and maybe then somebody else in your team will receive then the real answer, what is missing or what is needed for this patient, what is important. Then the third one is provide opportunities for patients and families to express the spiritual and or existential dimensions of their lives in a supportive and respectful manner. So you have to be genuinely interested. If you don't have time, then maybe just leave it. Don't do any spiritual screening. You really should have a little bit of time, and you really should listen what the patient is saying. So the way of being is a presence, that you are fully present in a situation. You are able to listen and pick up the words that the patient is saying. And here we know that physicians feel most comfortable to talk with people who they think they are most similar to them about spirituality. And that's why those who wording might be very different. That's why it is important to pick up the words and use the words, not your words, what you have learned to address this topic. But if somebody is saying, for example, I am drowning, then go from there. Why do you feel that you're drowning? Or something. We will have a little exercise also about this for self-reflection. So posing questions as responses to what is uttered. So you don't have to give answers. You just have to be there. Nobody expects you to go into deep theological conversations. Usually the things the patients utter surprise us, because we think, oh, spiritual care, now they want those supreme answers. What's the meaning of life? Not really. They just want somebody to listen. And I have some colleagues in Israel who just said that, patients want to tell me that I fell ill because I had a bad marriage, or I worked too much. And then if they want to go out of hospital and feel restless, so some of them just have a pet at home who needs to be fed, or they are afraid that their home is alone, and they just want to go there. And so with social work, if it's available, some of those issues can be or they just want to call someone, or even things like they want to have a smoke, and so enable that, and they are much more compliant already. So small things. And then the competence 4 is like be conscious of the boundaries that may need to be respected in terms of cultural taboos, values, and choices. And here, like lots of warning signs go up. So the myth of otherness, what I call the myth of otherness, is that there are special features typical to special groups of people. But in palliative care, we have the privilege to meet the person as an individual and not as a representative of a certain group. So if you and those people might have diverse health identities and if you think that you know something about this special group of people, then actually what happens is that you maybe build up barriers instead of getting closer to the person. You build a barrier and you make even mistakes, and this kind of cultural barriers are very well related to patient safety, for example. There are linguistical barriers, but also this kind of just like it's from a different group and they always want this. And so, no, it's not like this. Go to this patient and even be an advocate for this patient. Maybe their family has different needs than the patient. And also this kind of advocacy is here very important. So you find out what your patient actually wants and needs. So now we do a little practical exercise. Here is a story. I will read it to you. And this is an imagination. So you are on a duty and come to Miss S on your ward in the afternoon. You find her curled up in bed. Now you ask Miss S about her condition. Usually you would ask, how are you? Yes. Miss S is 38 years old, married and mother of 3 children. And a few days ago, she was admitted to hospital with a slight weakness on the right side and a speech disorder. She has considerable difficulty communicating verbally. She was told that she has a large, fast-growing and very likely malignant brain tumor. A biopsy was performed for further diagnosis. The histological result is not yet available. You approach Mrs. S and see that Mrs. S is holding a photo of her children in her left hand. She has obviously received this photo today. She looks at it, shakes her head, tries to say something, and can only produce fragments of words for the time being. Mrs. S seems hopeless and tearful. Then she says clearly and distinctly, "Why me?" Even if you don't work in clinic, now I just want you to, or ask you kindly, to go to this Menti and use this code that you see on this web page, and I will make it free so that you can give an answer. So, and the question to you is that, is such a situation familiar to you from your practice? So even if you don't work in neurosurgery, something similar, has somebody already asked you a similar question? You have 3 options. in already, but you can see that the tendency is towards that you have been confronted with this kind of situation, or even not, or maybe you have not recognized. So it is possible, and maybe you take it too seriously and think that I am not working in a clinic, and then I wouldn't have this question asked. And it could be also that this question is usually posed to a nurse more likely than to a doctor. But even so, we have 12 answers, and we have the majority of yes here's. So now we will continue with your part. Or you cannot say, so you're unsure. But still, now I want you to think about this lady who is with this photo. She cannot express herself very well, and she asks, like, why me? So I have to now see if I can go further. I have a second question to you as well. I will go to I have to go maybe out of here and then to the next slide. I'm sorry, it's always this technology, but we are getting there. So now maybe you can write with your own words, like, what is important to Mrs. S? So what do you think is important to her? Yeah, so you will have some yeah, so we see, yeah, we have to actually listen to her and find out rather than assuming. Her kids and the future, an active listener. Yes. Yes, that she has seen her children and now is hesitant what is going to happen to her. She's very young. So you see, so these are probably the things she wants to talk about or someone to listen about. And we have actually done a study on this, and then among nurses, not physicians, but we are going to do that as well. And so some would go and say like that, I will make you some tea and leave her be, for example, or tomorrow the doctor will be in house and he will tell you then what's the result of your tests, and then we go from there. And then this kind of nurses answers also report us of the hesitance, for example, that how do they communicate? Do they communicate as a professional or as a human being in this situation? And I think that you also have this kind of question in you, that should I be now the hardcore professional and wait up until the results come and then discuss it with her? Or am I just in this moment there for her and stay for a while until maybe she calms down a little bit? So, and always this question of time comes up, because in our workplaces, we just don't have time for this kind of situations to act as a decent human being. So, but it might not even be so time consuming. We know that the therapeutic, the therapeutic conversation starts like after 4 minutes or something like that. So it's really not that much time. And sometimes even if it's just like a half an hour, you avoid lots of problems later if you spend this half an hour with the patient. Okay, so thank you for this. Now we will, I have one more question for you. And this question is, how could you help Miss S? So it's the same place where you already were. What do you, yeah. So what do you think, how could you help? You're excellent students, obviously. I can see that this is like doing an interview and asking those questions, what do you think? And you immediately know what I expect from you, yes? Yeah, beautiful. Thank you so much. If we go back now to this, then when we summarize sort of like what is happening in spiritual care currently, then I have summarized it as some kind of 3 levels of void. So there is like this kind of void that what do we need spiritual care at all if we have palliative care? Is it the same than palliative care? And you know, if we do like manage the pain and so on, you know, yeah, that's the best care we have. And so why do we need the spiritual care at all? And then there is this kind of void at organizational level. And I think that this is like a guarantee for workers' well-being if there is space for spirituality, trust, and respecting each other, and making everybody at their workplaces like that they belong there and they're just not filling in something in this kind of busy environment. So team building and recognizing everybody's special competencies is very important. And so also making this kind of spiritual care provision and organizational tasks, a task can not only like that become spiritual and then the patients will benefit of it. So it shouldn't be an individual task. What happens, and you will probably like be a little bit laughing, but in Europe, it's very popular in hospitals to provide people like with this kind of McDonald's mindfulness courses for 6 weeks or some yoga courses, and then expect that they feel much better. You know, it's forgotten that spirituality is a practice. It has a character that, and sometimes after practicing, you feel even worse, you don't feel better. And then you have to just recognize that today I don't feel that well, and maybe somebody else can do this kind of serious talks, or if you're not in a place of doing it. And but there are lots of this kind of studies where really like healthcare workers get like training in spirituality, but nothing happens at the workplace. And so the following reflection is like also from our white paper where we asked across Europe people, so what are the main concerns why cannot we integrate spirituality into palliative care? And here are some things. So that spirituality and spiritual care are fuzzy terms. People do not like to talk about it. And we indeed have in Europe this problem that if you are a scientist and medical professional, it's not kind of seen as your cup of tea to talk about spirituality. And even like in some countries like France, religious talk at workplace is forbidden. So how do we integrate it into the healthcare if you cannot talk about it at your workplace? So then there is documentation of spiritual care and spiritual needs is not part of everyday hospital life. So you might ask about what's your religion to make assumptions then what kind of food you maybe like, but nothing else if patient comes into the hospital. And this kind of small spiritual screening, like that, what's the most important thing for you in this moment, is not really done or documented anyhow. And then there is this kind of medical spiritual care and pastoral care and psychology also, which focuses on emotions. But if somebody is very emotional, then also this person may have a spiritual need. And so they kind of drift apart. Then also this idea that spiritual interventions have risks and side effects. So not everybody should be encouraged to do a heart surgery. So why would we encourage everyone to do a spiritual intervention? You know, so if you can maybe open up the heart, but you cannot close it. And then you actually harm this person. And then also the spiritual care trainings, but in Europe that are sometimes, they are very expensive and last a long time. It's all about like hours that we should train people in this and this for hours, but it's not, it applies to palliative care education as well. It is not so much about hours, but it's about like meaningful things, you know, that we can teach people even in a very short time. And that's why the call that spiritual care training should be low threshold and affordable, and it should take place at workplaces in the work context, so where you could have like regular refreshers, that you have it in your mind, in the back of your mind, that okay, this is also something important. So we kind of looked at this. So there are lots of trainings, and this has been one of the topics that I have been dealing with for many years now. And so what helps to integrate spiritual care into practice? So you might go and have a training, and then you come to your workplace, and then you have this hidden curriculum that says we have no time here and we have always done things like this. So it seems, at least from the literature, which is very much from researchers with Christian background and or humanist background, but they seem all to be agree on that the cooperation with chaplains, who are then this spiritual care profis kind of, that this is one of the things that helps to integrate it into practice. There can be also spiritual counselors. Then this kind of teaching methods and learning to apply. So obviously during our online course, we cannot really do any application of our knowledge, and we don't get, so it should be some kind of simulation training or something like that, where you can also make mistakes and you get feedback, and you can, if you are like an ambitious person, you can go and do it again and again. Very important is to have role models and mentors, so that if you have someone who is very good, just keep close to this person and see how they go about patients and how they talk with them and what they do, and learn from that. And if you, for example, feel like that you need some feedback, then find yourself a mentor who helps you and teaches you and who gives you also feedback, and sometimes also helps you, gives you a supervision also, that because the situations can be very difficult. We deal with people, and mistakes happen. It's absolutely normal that mistakes happen. So, and then later we go home and we think, oh damn, why we were like this? And why did I told that? I should have done it differently. And so these kind of mentors can help you to come to start again, basically. And then time, relationship at workplace and working environment again can support integration of spiritual care. And then that we have this kind of training models, so that we, for example, next week on Friday, next week on Tuesday, EAPC will publish nurses' competencies in palliative care for undergraduate nurses. The physicians' competencies in medical education have been already published, and both those competency lists for undergraduate education have also the spiritual care component included. But the problem is that at the universities, we don't have people who would teach it. So obviously it is not taught. So in palliative care, you might have good end-of-life care, you might have symptom and pain management, you have ethical questions, but the teachers at the universities don't know how to teach, for example, grief and bereavement issues, or also spirituality and spiritual care. So this is a true bottleneck. So we need maybe more international models also, so that more people would have access to this kind of education and would have a common understanding that what is it about. And then also protocols for hospitals, so that so we would have a guideline how to do spiritual care work and how to follow it through. So some critical points as well, that like how this kind of training success is measured, that we always have this kind of training and then we measure it before and after, and then people report after in this assessment that now their competencies are better, their attitudes towards spirituality and religious are better, and they are very willing to provide spiritual care for patients. These assessments are done usually with this kind of written assignments or scale questionnaires, and there are very little studies assessing the long-term outcomes of such trainings, and there is also a serious lack of studies assessing the impact of training on the quality of care among the recipients, so among the patients. So does it really affect the patients if we train people in this topic as well? And so there are also some implications for future research. So if you are interested, for example, doing research in spiritual care, then yes, maybe focusing on patient outcomes would be nice. Then also, well, I would totally welcome. I have heard from my Indian colleagues that they say that, the Indian colleagues think that spirituality is something that only the Europeans find important. And in India, we are just different. I don't think so. I think that people are beyond religion, human beings all, and there are so many universal things that unite us as human beings. But I would be glad to come to India and study this with you, or do studies with you, and to be proven wrong, also. So also the question is that what we saw in those studies that we observe now was that spiritual care training may be discriminatory if you only represent like 5 major world religions, or you neglect their contribution in the curricula. So the question is, should you focus on religions and tell these kind of things that Jewish people want that and Christians want that, even though if you know that if you see just 2 Christians, they are totally different people and might have totally different needs. So the question is it reasonable to have this in a curriculum? And also like how to address people who say that they are agnostic or atheist, or even like have a multi-denominational background, and so how to deal with these issues. And also spiritual care training can have a negative effect of students, so that they feel that they are pressured to change their own worldviews of spirituality. So I want to be also very self-critical in this work that I have been doing and pursuing in the past years. But basically, to sum up, is that my message kind of is that to be a spiritual care provider, and this citation comes actually from a nurse, you have to be mindful of oneself, one fellow humans, and the world. And there is this French, I think also English, a philosopher, Paul Ricoeur, who encourages us to or who tells how human beings explain the world. It's very much put together of self-understanding. So we have a negotiation between a man and self, or women and self. Then there is this communicability where we talk with ourselves and others. So intrapersonal spirituality and interpersonal spirituality. And then this kind of referentiality where we negotiate with the world and the environment around us. And so yes, I think that spirituality is somehow vague and thin, this understanding, but there is something in it. And without that, we are much poorer if we don't focus on this area in our lives as well. So, but I obviously don't want to preach on this, but, and I am also myself a bad example. I sometimes forget to take care of myself because work seems always so important. So I stop now sharing, and maybe you put on your cameras, and I just really would love to hear from you. So what are your experiences and what are your concerns, and can you do spiritual care? Do you think you are good at it? What helps you? So lots of questions. Just tell me your stories. I love stories. So, and I will tell them then to other people. Or maybe you have questions to me, so please.
So there is a comment in the chat by Punita.
Or you
in
can
India,
comment.
population is so much that healthcare delivery can be delayed. Many patients don't know the diagnosis. I feel that's the cultural barrier.
I have to put my microphone a bit up. Maybe you could repeat the question, please.
Yeah. So Dr. Punita says in India, pollution is so much that spiritual care delivery can be delayed. Many patients don't know the diagnosis, and she feels that it's a cultural barrier.
Mm-hmm. Yes. Yeah. Well, if I understand this correctly, then, because again, I am not expert on India, I have just read novels from India, so that's my understanding. I've never even been there, so like I cannot comment on that, but I know that, for example, I had a very good colleague who studied mental health in India, and so he said, for example, that families usually first take their patients to spiritual counselors or some kind of this kind of, we would call it like a medicine man, local healer maybe, before, and have the idea that this person is possessed, you know, by some evil spirits or some ancestors. But this is like, again, a universal phenomenon. I don't think that it is something special for India. But obviously, understanding why people do it is very important, and negotiating. So again, like, what are their values and why they decide to do so. Maybe this healer is closer. Maybe this healer understands the family needs better. Even the Christina Buchalski, who has done lots of work on spirituality in the United States, she began also her work asking why people go to alternative therapy instead of healthcare, and what these alternative therapy or the CAM providers do better than the normal physicians, you know. So and it's a lot about like having time for conversation seems to be a key here also in some ways.
Dr. Punita says most of the patients, or at least maybe more than 50% of patients, would not know their diagnosis, and their family is very hesitant to talk about that diagnosis. They will interfere or they will collude with the doctor and nurse and will ask them not to tell the diagnosis or prognosis to the patient. So that makes it more difficult, so that the spiritual care is delayed. That's what Dr. Punita was talking about.
Yeah, we have had this problem, and we will partially still have in many European countries also this not discussing the diagnosis with patients on families' requests. But so this is about like hope giving and hope taking. This is a big problem and issue. So you kind of don't want to take the hope, and still you don't give your patients the opportunity to plan for the future. If you to do things that give meaning to their life, if you don't tell them the prognosis honestly. And then as you mentioned in the beginning that I did my PhD on cancer patients' experiences, and there were more than 700 cancer patients from Finland involved in that. And interestingly, those patient stories tell that, okay, yeah, doctor, for example, in 60s in Finland, it was also very typical not to talk about the diagnosis with the patient, but patients knew exactly what is happening to them, you know. So it's kind of ridiculous not to disclose the prognosis. And so it's just a change in the medical culture that we have to teach first to physicians, that the patients have a right to know what they are expecting, so that their end of life care could be better, Yeah, and so they could focus on, like, I still want to see my child graduating the school, I still want, you know, see this, and this can be little things, and these are the ones that feed your hope, kind of. And we are not taking hope by telling patients that what their prognosis is. We kind of support them to have a better quality of life, really. There are some comment, I will check that as well. If I can see it. Yeah. Yeah, and we have in Europe come so far that our families are so much in denial that if they have never visited their grandmother like 10 years in a nursing home, and then we call them that now your grandmother is dying, then they come and accuse the nurses and the physicians that they haven't provided good care. So this is the big part of our society that is in denial of death. And then, or I have seen also caregivers on the palliative care ward, like daughters, surprised that their mother is now dying, you know, so that this shouldn't become as a surprise. I think that it's also part of our education, and we should, I always think that schools are also like the places where, where we not idealize death, but to be open at least to discuss, like, what does it mean? Yeah. Oh yeah, silence is beautiful thing, really, because my students who work in ICU, for example, they will also go and come back with the reports after the lectures and say that, you know, I cannot talk to the patient, so what do I do? And so it's also just about being there. And being in silence, and lots of conversation happens in silence, and this is the Foucault has been writing about that. But then I always remember to tell my students also that just because you are there and you see this patient, even if you cannot communicate, you are doing a good job. And and providing good care. Yeah, so yes, silence is very, very important. And there is a good story about one chaplain in UK who said that when I go to a patient's room and the patient can falls asleep, you know, and this patient cannot sleep maybe when she or he is alone, yes? So am I doing my job or am I just wasting time if this person, when I'm there, can sleep? So this is a beautiful example how presence can help heal, even though we cannot treat this patient anymore, but this kind of, it provides a healing presence, just being there in the room so that the person can sleep. Yeah, so
And do you use any tools for assessing spirituality?
yes, there are. And on purpose, we listed in this white paper lots of tools, but it is quite fascinating that even the authors who have introduced those tools are rethinking their purpose, and they say that it is better to have your own question, kind of something that fits with your worldview and with your vocabulary. And so there is this tool FICA from Christina Buchalski. Yeah, Foucault, Michael Foucault has written about meaningful silence. It's a French philosopher. But yes, Christina Buchalski introduced this kind of FICA tool, and it has 4 semi-structured questions, and it's meant to be a short, this kind of spiritual history taking tool, but it can actually take quite long time. So we trained quite many healthcare professionals in Germany, and we didn't have a very good success with that. And it was because the healthcare professionals thought that these questions would be burdensome to patients, although patients felt that those questions were not so burdensome. And then our healthcare professionals whom we trained and who at the end of training thought that now they can do this assessment, they said that it was much more difficult than to talk about sexuality, to ask those questions about spirituality. So yeah, so there are lots of taboos and actually if you ask about religion or spirituality, it can be a conversation killer for many in Europe. So I don't know how is it in India, but well, yes, but like now I see, yes. Yeah, so yes, this is changing in time. So if the physicians are trained about disclosure, then it comes better. So, but this issue was in 60s, 70s still very much present, that the patients didn't know their diagnosis. I had a very good friend, her mother died when she was 6 years old. And she was told that her mother has tuberculosis and she cannot go and visit her, although her mother had cancer. So this is like from 70s still, it can, or even like beginning of 80s. So, and you can imagine what kind of trauma it is for small children if they cannot see their mother, yeah. And also the patient kind of was maybe left without the clear understanding what is happening to her. So this is a struggle still also in Europe. So don't think that we now freely here can have this problem solved. And it depends also on human beings' backgrounds. I have written about this in Israel, for example. Then they say that when people have very orthodox backgrounds, then it can be very difficult with disclosures, and others are much more liberal, then it's not such a big problem. So it really depends like what the values of this person are. And we know that like in Muslim tradition, treating until the very end is important. And also in some Jewish Orthodox groups, it's like that we only have this life and there is no belief in afterlife. So it means we have to do everything right now in this moment. But as I also mentioned, and somebody said that it would be important to teach to physicians about different cultures. I don't really believe that. This time is over. You should, like in 90s and even in 2000, there was still like, you know, if you have a Jewish person, they want this, and there was this kind of checklist. But people have now, when they move around, they have so many experiences, they might distance themselves because of their life history from their traditions, if they maybe come from countryside and end up in the city and meet like totally different people. So the life view might have been changed. And now when we approach this person as someone from a certain group, and we have a good knowledge because doctors are very good, they learn everything by heart. And now I learned it in this course, and there was this checklist that you must want this. So we make mistakes actually. So it's always better if communication is possible to find out that what you want. So I have, for example, colleagues who work in big hospitals in Australia and in Sydney. And so the palliative care physicians who say that there is like family coming and reading Quran, and this woman just cannot find her peace because she doesn't want that Quran is read to her, even though she like kicks then the family out of the room and reads poems instead. And, so something is being read. And so you also have to have this kind of executive power, in particularly in hospital. And just so that the person can die in peace, really. And so this kind of situations happen in our diversified world where everybody is somehow very, very different also. Yeah, so we wouldn't want us to be in some kind of boxes culturally or religiously. So we shouldn't do it with our patients as well.
In your practice, how do you explore spirituality? What questions will you ask?
Well, obviously, I operate in German, but I have a good question that yes, and so the spirit didn't work really in Germany, I have to say, because it was too long or so. So now my UK colleagues, and it seems it works in Germany as well, you go into the room and you would normally ask, how are you? Instead of asking this, how are you? I suggest my students to ask, what matters to you at most in this time or at this moment? What is the most important thing for you in this moment? And then go from there. And the second question would be that what can I do or what can we do for you? But it is a very easy question. It is different from this how are you, which is like a platitude, you don't even feel that you should answer to this. And you say, yeah, I'm fine. Yeah, and then this kind of question that what matters to you at most, or what is the most important thing for you? And if they say, I couldn't sleep, hey, try to let them sleep, for example. Try to organize that instead of doing the procedures, try to organize so that this person can rest a little bit. If they say, I haven't been outdoors and for days, and I am now, and this patient is maybe non-compliant, try to organize that this person can go outside for a second, and then they become more compliant. And one other question, which is very German, but what I use is also what empowers you, maybe would be the translation into English. So what gives you power, so the things in life that empower you. Yes, so it can be somebody tells that it's like cycling or I don't know, being in the nature seems to be one of the things that empowers people in Europe a lot. And so for palliative patients, that can be that every day you bring them some piece of nature, maybe some colorful leaf in autumn from outdoors, and this feeds their need, their spiritual need, being united with nature, for example. So it's really like not so difficult. And in areas where it gets very cold, and if you have a non-compliant patient, sometimes it can be that they have in a cellar their marmalades and I don't know, cucumbers. I don't know if you do stuff like that food-wise, and they freeze maybe there, and that's why they want to go home immediately. So it's like this kind of very material things also, or like cars. We always think like, I don't know, but for some people it is so important to have a car ride somewhere with their friends, for example, or just, you know, something that relates to or gives us the feeling of being free, of also being free from being a patient, I think. See, you have got me into this kind of teacher mode now. I like, you can't stop me really. You have to really switch me off then. But you can see, I hope you can see that I'm very passionate about this topic. And as you know, the meaning of passion is also suffering. So I also suffer a lot because of that.
I want to share one of my experience. This is with my grandmother. She passed away in the age of 88 or 89. She wanted to wear one piece of jewelry which her father bought, and which was taken away by her daughter-in-law, and they never returned it back. So until when she was in the death, she was not in the deathbed, like she passed away suddenly, very unexpectedly. But still she used to tell every time we visit her, you will remember to take that chain, no, from that aunt. So she always keeps the other ring and all, she used to keep under her pillow and make sure that the daughters are getting it. And she was so attached to that.
Yeah,
And
so things,
we
yes,
used
very
to,
little things. Yeah,
we
so
used to
probably
raise
she,
your,
I can, and everybody, I tell you,
so
it's very universal and human to have this kind of things. So it's not really this kind of big transcendent spheres. It's just something very tiny that can be for this person very, very important and significant. And if we find that out, we already have done something really good. Yeah. Yeah, and this can
we
be
had
like
to promise her that we will take that back. Don't worry, that will be back. We will make sure that when you are like, you know, just before cremation also, we'll make sure it will be on your neck and all. We had told her.
yeah.
Yeah.
Yeah, and so she found her peace of mind because you assured her we will take care of it. Yeah. So yeah, and this is also why also this kind of things, like when people have arranged our grandmothers are so wise, you know, they always had their dresses ready for the funeral, stuff ready. So they prepared for that. They knew exactly what they wanted. So why should we be more, you know, why shouldn't we learn from them? You know, they, and then I am a little bit sad that our society has lost this kind of connection, and we are like dead for a longer time than we are alive. So and this process of dying can be very annoying, I think, and it's scary also. So that to be well prepared for that phase, I think it's a smart thing to do, isn't it? So anything else that is on your mind?
Ma'am, I have one question to ask. Being a healthcare professional, has there any time that if somebody has a spirituality block, I don't know, is there any particular term for that? If at personal level, someone has a spirituality block and thus it will impact at the work level, what can be done during those situations when you yourself are struggling with thought block or that our own personal path?
Yeah, well, I think that it is something is what helps, in my opinion, is always writing down what the things that are good for you. So writing can be a very strong medium for understanding yourself. But nowadays we also have cell phones, so you can also record your thoughts and listen to them yourself. So and then you give yourself a lesson about like what your need is and how to go about it. If you maybe hear yourself verbalizing your need or your burnout or your suffering or your struggle, either writing or listening to it. I think like really everybody has a phone. It sounds like silly idea, but like record your thoughts and listen to it, what you are saying, and go from there. And then maybe you know, if your friend would be asking you, you would have good ideas how to go about. So be your own friend and suggest yourself something good. Okay. I don't see. Yes.
Yeah. So I think spirituality is such a it is not a very confined topic. It is a broad topic, and uh, everybody is trying to find out the meaning. And I'm sure all of you are trying to find out the meaning, and maybe we would know it better when we go through our experience. Um, so once you understand about spirituality, then as Dr. very well told, and we can see how the patients are making spiritual sense. Um, so thank you, Dr. Piret Paal, for being with us and giving your thoughts on spirituality. Um, and definitely it will benefit all of us. Thank you so much. And Sophia, sorry.
Thank you, Professor Piret Paal. Thank you so much. It was very enlightening listening to you, especially the session was very interactive with the practical activities in between. Thank you so much for bringing that in. I hope everyone would have enjoyed just like me. Thank you once again for joining us, and we wish you a peaceful day ahead. Even though we are signing off for the day, it's almost night here, but we do hope that you have still day left over there. So wish you a peaceful day there. And thank you everyone for joining in, and with the promise that we'll be meeting again for another session with another eminent faculty. This is Sripriya along with Professor Piret Paal and Dr. Sunil Kumar signing off from the Palliative India's desk. See you in the next session. Till then, everyone, take care. Bye-bye.